Hey guys, welcome back to ST3 Hacks, and today we're going to continue the pediatric theme and talk about DDH, which stands for Developmental Dysplasia of the Hip. Now, this is a spectrum of abnormal hip development, ranging from instability to subluxation to established dislocation, and it may be present at birth or develop postnatally. The underlying issue here is abnormal acetabular development with insufficient coverage of the femoral head. It's often associated with ligamentous laxity and intrauterine mechanical fractures. The key pathological principle here is that there is failure to maintain concentric reduction. If the femoral head is not well seated in the acetabulum doesn't develop normally, and this is where the problem lies. Now, radiologically, on the AP pelvis radiograph, you can see a few signs. So the first is Hilgenreiner's line, which is a horizontal line through the trigradiate cartilages, and it forms the reference for measuring the acetabular index. The acetabular index is an angle between Hilgenreiner's line and the acetabular roof. An index of more than 25 degrees after 6 months is generally considered abnormal, and values may vary with age, so interpretation must be age-specific. And I would really look at images of an X-ray to understand this. And the next line that you need to know is Perkin's line. It's a vertical line perpendicular to the Hilgenreiner's line at the lateral edge of the acetabulum. The femoral head ossific nucleus should lie in the inferior medial quadrant formed by the intersection of these lines. And another line that you should know already through med school is Shenton's line, which is a smooth arc along the inferior border of the superior pubic ramus and the medial femoral neck. And disruption of this suggests subluxation or dislocation. In infants under 6 months, ultrasound is the investigation of choice as the femoral head has not really ossified yet, and so you can't really use an X-ray to its full potential. Risk factors that you need to be able to really reel off are breech presentation, female sex, so the ratio is more like 6:1 with female predominance, firstborn child, a family history of DDH, oligohydramnios, and twin birth. At ST3 level, it's important to demonstrate that you consider secondary causes, and you should say, I would actively assess for underlying neuromuscular or syndromic conditions such as cerebral palsy or spina bifida, as management and prognosis can differ. Examinations for DDH under 3 months include Barlow and Ortolani tests. So Barlow's test attempts to dislocate an unstable hip by adducting and applying posterior pressure to a flexed hip. Ortolani attempts to reduce a dislocated hip through gentle abduction and anterior lift behind the hip joint. These movements really become unreliable after around 3 months due to soft tissue contractures. And between 3 months to 1 year, the most consistent clinical sign is restricted hip abduction. So abduction less than approximately 60 degrees or any asymmetry between the hips should really raise concerns. And the last is Galeazzi test may also help here, which may demonstrate apparent femoral shortening in unilateral cases. In late presentations of children above the age of 1 year, there could be signs such as the Trendelenburg gait, pelvic tilt, limb length discrepancy, and a fixed flexion deformity. And reduced abduction remains the most reliable sign. Look, the red flag is if there is any child with asymmetrical abduction or leg length discrepancy, they should be referred urgently to pediatric orthopedics to rule out DDH. Investigations, as we've mentioned, ultrasound is the gold standard under 6 months and is used in selective screening within the UK. Radiographs used between 4 to 6 months when ossification begins. An examination under anesthesia with an arthrogram is used prior to closed reduction in cases to confirm reducibility and identify the blocks to reduction. MRIs can also be increasingly used post-reduction to confirm concentric reduction while avoiding radiation. CTs may be used in some centers, but MRI is really the preferred imaging choice in pediatric practice due to the amount of radiation that children may be exposed to while they're young. Okay, so talking about the management, the principles here are you want to achieve and maintain concentric reduction, allow normal acetabular development, and minimize risk of avascular necrosis, reducing long-term osteoarthritis risk. Management is age dependent. So in a child under 6, you want to use a Pavlik harness. So this maintains the hip inflection and abduction while allowing some movement and requires careful monitoring to avoid femoral nerve palsy and ABN. Failure rates increase in fixed dislocations. In children within 6 to 18 months, the closed reduction under GA with a hip spiker is the preferred method of treatment. Typically, you do an EUA and arthrogram where you insert a dye and then take an X-ray within the hip joint to see if it's reducing properly. gentle reduction, and then spica cast in a safe zone of flexion and abduction of the hip. The cast is usually maintained around 12 weeks, often changed at 6 weeks due to care issues, and then repeat imaging is often performed. In children over 18 months with failed gross reduction, an open reduction may be required, and there's adjunct procedures which perform intraoperatively, and they may include an adductor tenotomy, a psoas release, a femoral shortening osteotomy, and a pelvic osteotomy, depending on age and acetabular development. Now, these are quite specialist things. It's just good to be aware of and push your knowledge as you go into ST3 and prepare for the interview so that you're not taken by surprise. And if you really consolidate this knowledge, you can show off in the interview. Now, how you may perform a spica cast reduction. I've actually recently done this as a pediatric ST3 trainee, so I'm going to talk to you about it. In an appropriately consented and marked patient with senior pediatric orthopedic supervision, you should perform an EUA to assess stability and reducibility of the joint, perform an arthrogram where you insert a dye into the hip joint. You use a medial approach. The needle is inserted under the adductor longus tendon, which is directed towards the ipsilateral nipple, and confirm capsular entry and inject a small volume of contrast. Normally it's diluted contrast solution. On the arthrogram, I would assess if the hip is concentrically reduced. I would check for medial dye pooling, and more than 5 to 7 millimeters suggest interposed tissue, and ask if I can see any blocks to reduction. Now, there are many blocks to reduction. They can be intra or extra-articular. Intra-articular is the pulvinar, which is fibrofatty tissue, an inverted labrum, a hypertrophic transverse acetabular ligament, the thickened ligamentum teres, which is the head of the which is at the head of the femur, and then extra-articular things could be a tight capsule, a contracted iliopsoas leading to an hourglass constriction. If there is satisfactory reduction achieved within the safe zone, a hip spica is applied at approximately 90 to 100 degrees of flexion and safe abduction to avoid excessively abducting the hip, which may cause AVN risk. And then to finish your spiel, you should say, I would ensure post-procedure that imaging confirms this reduction, and if not, you escalate to open reduction with specialist pediatric senior support to ensure that the hip is corrected. Okay, so I know this is a lot of content and it's quite specialist. I would read around DDH on Ortho Bullets, watch some videos, and really take this in. And in that way, you won't be surprised or intimidated if this is the stem in which they're pushing you within the interview. The trend has been that mostly it's, acute trauma things, but they are liking to test knowledge to differentiate candidates further. So I would have a thorough read, and I wish you luck in your revision. Catch you in the next one.